Bismillah ar-Rahman ar-Rahim. Today's lecture is about physiology of coronary circulation. Coronary circulation. Who will tell me what is the meaning of coronary? Why it is named as coronary circulation?
It's about the heart.
It's about the heart, but why the name is given coronary?
Is it the main
The
blood
medical
supply,
term.
main circulation for the heart?
Okay, but why the name? Coronary came from which term?
Like a
Crown.
crown.
Very good. It is like a crown. That's why it is named as coronary circulation. Let me change my color. Okay. So corona, it came from corona, which is nothing but like a crown. Like a crown. Like this is a crown. But where is the crown? We will see now. Okay. So coronary means the arrangement of vessels, arteries are like a crown sitting on the heart. Why we want to study this lecture? Coronary circulation, why it is important? Because you know that in KSA, about 42% of all deaths are due to cardiovascular diseases, which are related to either hypertension or related to ischemic heart disease, and they are indirectly related to our coronary circulation. So for every doctor to know the information about the coronary circulation, because it is a very important aspect or important topics for dealing with 42% of the diseases or deaths. 42% of the deaths. Okay. Okay. In this lecture, what we are going to see, we will see very brief anatomy of the coronary circulation. Brief, not in detail, because it is anatomy. We would like to spend more time on physiology of coronary circulation. And one more important thing is that the circulation is not regular. It's not like flowing like this, but it is going up and down. It is in phases. Coronary circulation occurs in phases. It is phasic changes are seen in the coronary blood flow. That's why we will see how the phasic blood flow is occurring in coronary circulation. What are the factors which will affect the blood flow, making it more or less, or why it is changing? So what are the factors affecting the coronary blood flow, and what is its significance in IHD? Recognize the clinical significance of ischemic heart disease. Sorry, let me silent. Okay. So these are our objectives for today's lecture. That means at the end of this lecture, everyone should be able to describe the brief about what are the arteries responsible for supplying the blood flow to the heart muscles, and what is the importance of phasic changes in the coronary blood flow, and what factors are deciding the flow to be more or less, factors affecting, and what is the importance of coronary circulation in ISD or ischemic heart disease. So coronaries are these, as we said, that these are the arteries which are sitting on the heart. Just let's say this is the heart. So they are making a circle here, and then tributaries are coming like this. So this is how the crown is like this, not in this way. Okay. So the vessels are at the base starting from here of the heart and then supplying to the muscles. There are two main arteries, which are right and left coronary artery. This is left LCA is left coronary artery, and RCA means right coronary artery, right coronary artery. So these are the two main arteries. From where it is coming? It is coming from, if you remember how the aorta starts, sinus, and then it will go down, right? from the left ventricle. Let me erase some part of it. So this is the what I am making now, the aortic valve. This is an open aortic valve, and the coronary arteries are coming from here, from the right side and from the left side. Okay, so these are the two arteries. This is right coronary artery and this one is left coronary artery, and they are coming from the sinus of aortic sinus from here. Okay, and this is a valve. Let me erase some part of it. Sorry. Like this. Like this it is coming. So here is the this one is right, this one is left. Okay, what are the branches of left coronary artery? Left coronary artery, as soon as it comes out, it gives rise to three branches. Left anterior descending artery, which is known as LAD, marginal artery, and circumflex artery. Circumflex means the one which will make a round or curve. Okay, this is circumflex. I will show you in the picture now. And similarly, right also has got marginal artery and posterior descending branch. So these are this is the picture showing you. This is the starting of the aorta. From the aorta, there are two coronaries are coming out. This one is left and this one is right. Okay. Once they come out, they will give rise to branches. Left will give out circumflex branch because it is moving to the backside, making a curve. That's why it is known as circumflex branch. And then there is a anterior descending branch, which is in the anterior interventricular groove. And then there is a marginal artery also. The posterior right coronary artery also gives rise to marginal artery and posterior descending branch here in the posterior dotted lines because it is on the opposite side. That's why it is shown in as dotted line. Okay, as shown in the picture, left the coronary artery is supplying to the left atrium here and left ventricle, whereas right coronary artery will be right atrium and right ventricle, anterior part, posterior part, like that. Again, on the right side, right coronary artery is mainly supplying to also SA node, AV node also. SA node and AV node also. Right coronary artery, nodal branches. Okay, we will not go in detail about the supply because this is just anatomy and how the venous drainage is occurring. Venous drainage is occurring from anterior cardiac vein and into the coronary sinus into directly opening into the right atrium. So this is the venous drainage. Let us come to the physiology now. Physiology of coronary circulation. Coronary blood flow to the human heart at rest, when you are at rest, not doing anything, sleeping or sitting down, relaxing. At that time, around 225 to 250 ml of the blood is supplied per minute. In 1 minute, how much blood supply to the myocardium is through the coronary artery is about 225 to 250 ml, which is equal to 5% of the cardiac output. We have seen cardiac output in the previous lecture, that which it is around 5 to 5.5 liters. So out of that, 5% is 225 to 250 ml of the blood per minute. It is per minute. Out of that, suppose 250 ml of the blood is bringing, let's say, 100 ml of oxygen. For example, let's say 250 ml of blood is bringing 100 ml of O2 to whom? To the cardiac muscle, to the cardiac muscles. Suppose this amount of oxygen is coming through the coronary circulation. Out of that, the cardiac muscle will extract around 60 to 70% of the oxygen. Out of 100 ml of oxygen, 60 to 70 ml will be extracted from that blood. So how much is remaining? Remaining blood oxygen will be only 30 ml or 30%. Only 30% will go to the venous side. Okay. Whereas if the similar amount of blood, if similar amount of oxygens, let's say 100 ml of oxygen goes to skeletal muscle, resting skeletal muscle, then it will extract how much? It will extract only 25% of the oxygen, or you can say 25 ml of oxygen. 25 ml of oxygen will be extracted, not 100 ml, not 70 ml. This shows that the supply of the oxygen through the coronaries is, if you want to increase, let's say this is during rest, 70% of the oxygen is extracted. If suppose the person is exercising, at that time, you require less amount of oxygen or more amount of oxygen?
More amount of oxygen.
More amount of oxygen. But here remaining is only 30%. 70% is already at rest, is extracted, removed. So to increase the oxygen supply, what we have to do? We have to increase this amount, blood flow. We cannot increase the extraction. For skeletal muscle, yes, it is 25 ml is extracted, 70 ml is still remaining, 75 ml is still remaining. So it can increase up to 70% more. But for cardiac muscle, they are already utilizing 70% of oxygen from the normal resting cardiac output. So to increase the oxygen supply, we have to increase the blood flow, not the extraction. Okay. But what is the reason why the heart is extracting this much amount of oxygen at rest? Because the heart muscle has more mitochondria. It is said that 40% of the size of the cardiac muscle is filled with mitochondria. And what is the role of mitochondria?
Make ADP.
Make ATPs. After with the aerobic metabolism, they are making ATP. With utilization of oxygen, they are making ATPs. So they have got lot of mitochondria. Around 40% of the cell size is occupied by mitochondria. So they utilize, they extract more oxygen, they prepare more ATPs. The heart muscles are working throughout the day, 24 by 7. They are not stopping anytime. There is no rest for them from the birth till the death. They are working. So they are doing maximum job, and that's why they are extracting more oxygen from the rest, even at resting. So when in case of exercise, let's say when you start exercising, walking, running, climbing the mountain or hill or going upstairs, at that time you require more oxygen. So that more oxygen can be supplied by increasing the flow, by increasing, instead of 250 ml per minute, you have to increase 500 or 750 or 1 liter, depending upon the amount of work the heart is doing. So you have to increase the flow, not the extraction. Okay. So how the the flow to the cardiac muscle from the coronaries? It is said that, if you remember, suppose this is the heart. Suppose this is, my drawing is not so good, but let's assume this is the heart. And if you take a cut section, let's say these are the, sorry, I'm not drawing properly. Let's say this is the you can say the cavity, and here is the, I am drawing it wrong because this is right side. Consider it at right side because it is thin, and this is left side, and this is the interventricular septum. So this is a thick vessel, a thick muscle, and the blood supplies from outside to inside. There is blood here, but this is not utilized by the cardiac muscle. Here the blood is present in the cavity, but it is not utilized by the cardiac muscle. Blood has to go through coronaries and then come here from outside. Okay. Let's say left coronary bring the blood. So blood will travel from here to here to here till the last. So if you divide this area you will find this, there is a epicardium outermost, then there is a myocardium, the middle one, and there is a endocardium, the innermost. These are the three layers of the cardiac muscle. So blood is passing from epicardium to endocardium through this area, and this is lying within the muscle. What is happening during systole? What is happening during systole? There are two phases of the cardiac cycle. What are these two phases?
Systole and dystole.
Systole and diastole. What is happening in systole?
Contraction.
Contraction. So muscles are contracting. These muscles are contracting, these muscles are contracting. Let's say this is the artery and it is passing through the muscles. So once the muscle contract, what will happen to the artery?
Constrict.
Constrict. There will be pressure from outside, so it will narrow down, it will become constricted. And what is happening during diastole? Muscles will be
dilated,
relaxed. They will be relaxed and the artery will become dilated. It will increase in its shape, okay, or in the caliber. So it is because of this, the blood flow to the heart muscle reduces during systole and increases during diastole, mainly to the left side, What are the two reasons? One reason I told you that during systole, there will be constriction around the vessel. This will lead to decreased blood flow. Second reason, if you remember my previous slide, this slide, if you remember that how the coronaries are coming from here, you can see it here. Coronaries are coming from the sinus, aortic sinus, from left side and right side. Okay. And there are, what are these two? What are these? Can you say
valves.
it? Valves. Which valve?
The aortic valve.
Aortic valve. Very good. So aortic valve, these are two semillinear valves. Two flaps are there. So they are opening. Once this area is open, that means aortic valve opens. This is partially closing the entry of the starting point of the coronaries. They are partially closed here because of the flaps open, and they are closing the opening of coronaries. This is the reason. Two reasons are there. Second reason is open aortic valve will partially blocks the entrance of the coronary vessel. Suppose this is the coronary, right? I will draw it again here. So this is the entry of left and right coronary artery. And open valve means it will open like this. So it is partially blocking this area, These are the two reasons why the blood flow to through the coronaries is not a smooth line, but it is in phases. Increasing and decreasing. Okay. If you draw it on the paper in the form of graph, this is the coronary blood flow ml per minute. And these are the two durations, systole and diastole. So during systole, when the muscles are contracting, the flow is decreasing. During diastole, when the muscles are relaxed, the coronary blood flow will increase because it is relaxing or dilating the vessel like this, or making it open properly. Here it is constricted, so flow will decrease. Here it is dilated, so flow will increase. Okay. So remember, during systole, blood flow decreases. During diastole, blood flow will increases. Okay. And this is mainly seen, I am telling mainly, not always, mainly seen on the left side. Left side means left ventricle, left ventricular muscle. Why left ventricular muscle? Because these are very, very thick. These are thick muscle as compared to the right, which is thin. Okay. So coronary blood flow to the right side is not much affected. As I told you, during systole, the flow will decrease, but this decrease will be seen on the left side mainly, not on the right side. Why right side is not much affected during systole? Because the flow will occur. Whenever we say flow is occurring, suppose this is a vessel, the flow will occur because of the pressure difference. Suppose pressure is here 100 mm of Hg and here is 10 millimeter of Hg. Okay, millimeter of mercury. So flow will be from higher to lower side. This is pressing here and this is will be lower side. So flow will be like this. So there should be a pressure difference. This is called as gradient, pressure gradient. So based on the pressure gradient, the flow will be there. And the reason why the right side is not much affected, because the pressure difference between aorta and right ventricle is more. Suppose this is aorta and suppose this is right ventricle, RV. So if it is this gradient is more, flow will be more. And that's why there will be not much affection of blood flow during the systole. To understand the pressure difference, this table you have to remember. If you understand the table, then it will be very easy to remember. What are these numbers showing? Here it is showing pressure in millimeter of mercury in where? Aorta, left ventricle and right ventricle. So during systole, what is the aortic pressure? During systole?
120.
120. And during relaxation, what is the pressure in the aorta?
80.
80 millimeter of mercury. What is the pressure in left ventricle during systole?
121.
121. Why it is more?
To exceed the pressure of the aorta.
Yes, to open the valve, if you remember, the aortic valve will open if this pressure here, the pressure should be more than the pressure here. So if it is 120 here, it should be 121 or plus. Then only it will open the valve, right? So that's why it is more pressure here in the during the systole. Left ventricular pressure is 121 to open the aortic valve. And during diastole, during relaxation phase, when the ventricles are relaxing, the pressure will go to 0. It will completely relaxing, no pressure. Okay, so 0. Similarly, right ventricular pressure during systole is how much?
25.
25 millimeter of mercury. Okay. And during diastole, it is 0. Same. Why it is 25 in right ventricle? Why not more like same like left ventricle?
No resistance like in the.
Yes, if you remember, the heart has got left and right ventricle, and this one is pushing the blood to the pulmonary side, to the pulmonary side. Right ventricle is pushing the blood towards the pulmonary side, which is low pressure and low resistance. Low pressure and low resistance circulation. That's why it is not much. It is only 25 millimeter of mercury. Now let us see the difference. Difference between aorta here. Pressure difference between aorta and left ventricle. What is the pressure in aorta during systole?
120.
120. Difference means minus 121. How much?
-1.
-1. So what we have seen, if there are two ends of the artery or any vessel, if the pressure is high here, low here, then the flow will be like this. If the pressure is low here, more than or maybe lower than this side, then the opposite circulation will occur. You can say there will be zero circulation during systole. Why? Because it is negative, no circulation. Left ventricular muscles will receive very negligible or no blood during systole. Whereas in diastole, 80 minus 0. Answer is, difference is 80 millimeter of mercury. So there is some pressure difference. So that's why flow will be restored during diastole. Compare this with the right side. Right side aortic pressure is 120 and right ventricular pressure is 25. If you make a difference, 120 minus 25, how much?
95.
95. So there is difference. There is difference. So the circulation will be there. There will be circulation during systole. During diastole, 80 minus 0. Similarly, in the right ventricle is also 0. So it is 80. So during diastole, there is no problem. During systole also, there is no problem because there is some pressure difference, and that's why there will be circulation on the right side, whereas left ventricle will reduce the blood flow to the negligible amount during the systole. So this table shows you pressure difference and the flow. So as systolic pressure in the left ventricle is slightly higher than in aorta, blood flow will reduce. On the other hand, pressure difference in aorta and right ventricle and aorta and right atrium is more, like 95 in systole than in the diastole. Coronary blood flow is not appreciably reduced. So right side will be okay and left side will have reduced blood flow. Okay. This is how it can be seen. This is the aortic pressure changes. During systole, it will be very high, and the diastole it is reducing. Whereas in the coronary blood flow, if you see, it will be less in systole and more in the diastole. But whereas right coronary, it will be similar to the during systole, it will be same, but during diastole, it will be not much affected. Here, it will be increased in diastole. So I told you that blood flow is going from outside to inside, outside of the ventricle to the inside. So if you remember the layers, first is epicardium, then myocardium, and then after myocardium is the endocardium or subendocardium, you can say endocardium. So here is shown, and sorry, this diagram shows you these are the this is the right ventricle, this is the left ventricle, and if you enlarge the thickness of the muscle, you will find this outermost is the epicardium, the middle one is the myocardium, and the innermost is the endocardium. So this is the subendocardial area is the last to receive the blood. Blood is coming from here. So during systole, already there is no blood flow. So the least oxygen or blood reached here is the subendocardium. So therefore, during systole, blood flow to the subendocardial surface of the left ventricle is almost zero, not there. So this is the most important site or most common site of ischemic heart disease, subendocardial tissues of the left ventricle, because of the flow is occurring from outside to inside. Okay, now we have seen the blood flow is phasic to the left ventricle, or you can say even to the right ventricle. Which phase the blood flow is maximum?
Diastole.
During diastole. What is the normal cardiac cycle time? Cardiac cycle time, how much?
0.8, I think.
Yeah, 0.8. When it will be 0.8? When heart rate is 75
70.
beats per minute. Because we divide 60 divided by 75, it will give you 0.8, right? Okay, out of this 0.8, how much systole and how much diastole?
0.6 diastole
Mm-hmm.
and 0.2 is the systole.
No, it is 0.3 systole and 0.5 is diastole. This is how it is distributed if the heart rate is 75 beats per minute. Suppose the heart rate increased to 100 beats per minute. What will be the cardiac cycle time that time? 60 divided by 100. This is the option. The 60 divided by 100. How much? What is the answer? 0.6 seconds.
0.60.
0.6 seconds. Out of 0.6 second, how much is the systole and diastole now?
0.1.
No, systole time will remain 0.3. Diastole time will be how much?
Reduced.
Reduce 0.3. It may be 0.25 or 0.2 something, but it will be reduced. This is the diastolic time. Main aim is to tell you that during tachycardia, this is tachycardia, 100 beats per minute is increased heart rate. If the increased heart rate occurs, there will be reduced cardiac cycle time. This will reduce to decreased diastolic time. Okay. We told you before that circulation to the left ventricle is maximum during which phase?
During diastole.
During diastole. Okay. If diastolic time is decreasing, what will happen?
Decrease blood flow.
There will be decreased blood flow. So if suppose XYZ person is there, his artery is or coronary is like this, partially blocked. Suppose because of the atherosclerosis, this is partially blocked and he is doing normal routine activity. So there will be normal blood flow because it is not much affected, 50% is blocked. But if suppose that person goes to exercise, if it is doing exercise, what will happen? His heart rate will increase. His heart rate will increase. Okay. What will happen to the cardiac cycle time?
Decrease.
It will decrease 0.6 or less, maybe some. What will happen to the diastolic time?
Decrease.
Decrease. And we know that the blood flow is occurring during diastole. So the blood flow already partially blocked and he will have reduced blood flow, which will lead to ischemia or chest pain. Normally he is having normal at routine activity, he is facing no problem. But as soon as he increases the activity or his heart rate increases, he feel pain because of so many things. Diastolic time decreases and decreased blood flow, and this will lead to ischemic changes and person will feel chest pain or ischemic pain. Okay. So during tachycardia, this is the reason why during tachycardia only the person will feel chest pain if it is partially. If it is completely blocked, even rest he will fail. He will feel pain in the chest. Okay. You got the point now? What is the effect of tachycardia on coronary blood flow? Yeah, because of the phasic nature of the blood flow. And this will be mainly to the left ventricle and mainly to the left subendocardial tissues. Okay. Now we already said in the beginning that the only way to increase the oxygen supply is through increasing the blood flow. So what are the factors which are affecting the blood flow through the coronary arteries? One factor we have discussed already, that is pressure in the aorta. If the pressure in the aorta changes, there will be change in the difference in the pressure and this will lead to decrease or increase blood flow. Similarly, there is another factor which is most important. One is the most important factor is chemical factor. And third one is the neural factor because of the sympathetic and parasympathetic stimulation. Okay. It is said that coronary blood flow shows auto-regulation. What does that mean? What is the meaning of auto-regulation?
Doesn't need external stimulation.
Yeah, autoregulation means regulation of the blood flow within the organ, not from outside. Somebody will not send the signal to increase or decrease the blood flow. It is within the same organ, that is within the heart only. It will increase or decrease its blood flow through the coronaries. Okay, based on the need. Suppose the cardiac muscles are exercising or are contracting and relaxing more time, heart rate increases, the blood flow should increase by itself, not from outside. Something will not come from outside. This is called as autoregulation, means within the organ itself. Okay, what is the cause of decreased blood flow to the left ventricle during aortic stenosis? Aortic stenosis means what?
A failure of the valves.
Constricted valve. The opening is very small. It will become very small, not opening properly. Not opening properly. If it is not opening properly, what will happen to the left ventricular pressure? Because it is the one which is trying to open it. What will happen? It will move forcefully. It will have more blood, like more systolic pressure. We have seen 121. It may go up to 150 or 170 because of that reason. So if it increases like that, then there will be, initially it was -1. It may become -20 or something like that. So that's why during aortic stenosis, the coronary arteries will receive less blood. Left ventricular pressure is very high during the systole, therefore it compresses the coronary arteries more. And also when diastolic pressure in the aorta is low, coronary blood flow will be decreased because the blood is not coming out. During relaxation also there will be less blood flow, so there will be decreased pressure in the aorta, which will have decreased difference. That's why aortic stenosis leads to decreased coronary blood flow. Now coming to the most important factor which is regulating the coronary blood flow is chemical factors. What are these chemical factors which causes vasodilatation? This is a normal size. This is smaller size. This is big size. Normal. What do you call this one? Vaso
Constriction.
constriction. Very good. Because this is decrease in size. What do you call this one?
Vasodilation.
Vasodilation. Sorry, dilation. Vasodilation. So increase in the size. How it happens? How it happens because of this chemical. When oxygen decreases, when oxygen supply to any tissue decreases, the coronaries will dilate. When oxygen decreases, it may increase the CO2. So if CO2 increases, it will also vasodilate. If you know that CO2 if accumulates and there is water, this will lead to formation of H2CO3, which will dissociate into H ion and HCO3 ions. Okay, so this is indirect effect of the CO2 accumulation. This will also causes vasodilatation. And accumulation of potassium ions also lead to vasodilatation. And some chemical released at the local area like lactate due to anaerobic metabolism, lactic acid and lactates are formed. This will also cause vasodilatation. Release of prostaglandins also cause vasodilatation. Adenosine release also cause vasodilatation. Adenine dinucleotides also cause vasodilatation. What is adenosine? From where it is coming? Because this is very important chemical factor which is causing vasodilatation, coronary vasodilatation. From where it is coming, adenosine?
From the mitochondria, ATP.
Good, because we have seen in the beginning that there are 40% of the cell size is occupied by mitochondria, which are producing ATPs, and they are broken down to ADP, then it broken down to with one inorganic phosphate, and then AMP, to give one inorganic energy, and then it will become adenosine. After AMP, it will become adenosine. So here is the accumulation of adenosine will lead to vasodilatation. It's a very important vasodilator substance. Okay, neural factors, sympathetic and parasympathetic. This requires your attention. This requires your more attention to understand the effect of sympathetic and parasympathetic stimulation. Sympathetic stimulation lead to two things. It acts through two receptors. One is alpha receptor and another one is beta receptor. In heart, we have got two types of receptor. Alpha in the coronaries, beta in the where betas are present in myocardium, muscle. If suppose sympathetic is stimulated, it will cause stimulation here and stimulation here, right? Because it will work through both alpha as well as beta receptor. We are talking about now the blood flow through the coronaries. Okay. So what is the direct effect of sympathetic stimulation on the coronary or any blood vessel? Can anyone tell me? What sympathetic constrict? Yes, it will become constricted. Very good. Very nice. Okay. And you know that sympathetic stimulation to the muscle myocardium has got two effects. What are these two effects on the myocardium? Increase in rate of contraction and increase in force of contraction, right? Have you seen this effect? Chronotropic and ionotropic effect. If you remember the autonomic nervous system from the foundation block, or maybe in this block also, two effects are seen on the sympathetic stimulation. It will increase the rate of contraction as well as the force of contraction. Okay. Whenever the muscles are contracting and relaxing forcefully, what will happen? This will happen. There will be decreased oxygen will be there. There will be increased CO2. There will be increased hydrogen. There will be more potassium. There will be more lactate. There will be more adenosine because of muscle contraction here, myocardium. This will lead to what? Tell me. What will happen if muscle
increase the rate and force?
Yes, increased rate and force will lead to all these things. The one which I told you. More utilization of oxygen. Got it? There will be more accumulation of CO2. There will be more formation of H ions. There will be more potassium. There will be more lactate formation. There will be more adenosine. So what will happen?
Increase
What
the
will
rate.
increase the rate? Coronaries. What will happen to the coronary blood flow?
The decrease.
Why? Here it is causing chemical factors causing vasodilatation. Meaning what? Increased coronary blood flow. Increased coronary blood flow. You got it or no? See here. Sympathetic stimulation will lead to effect through the alpha adrenergic receptor on the coronaries constriction, which will lead to decreased blood flow, right?
And the coronary arteries, doctor?
And on the through the beta receptor, it will cause muscle activity, increased rate and force of contraction. This will lead to increased CO2, decreased O2, increased hydrogen, increased lactate, increased adenosine, and this will lead to vasodilatation. You got it or not? Sympathetic stimulation will have two effects. One is direct effect is through alpha adrenergic receptor, which is causing vasoconstriction. But indirect effect through muscles, it will cause chemical factors and it will lead to vasodilatation. If you compare between alpha and beta receptor stimulation effect, this effect is more than this effect. The second one is more powerful than the first one. So that's why ultimately this will be vasodilatation. coronary vasodilatation due to sympathetic stimulation. Okay, here it is showing effect of sympathetic stimulation on the intact body is vasodilatation, but the direct effect of sympathetic stimulation is on the coronary artery is vasoconstriction. Why? Because it is acting through alpha adrenergic receptor. But indirectly it is causing vasodilatation because of all these beta adrenergic receptor stimulation that is causing through muscle metabolism. So indirect stimulation of the sympathetic nerve releases norepinephrine, increases heart rate and force of contraction through the beta 1 receptor, which is leading to all chemical factors which are causing vasodilatation to be released, lead to vasodilatation. How we can see whether it is a direct or indirect effect? If you block the beta effect by giving some beta blockers, then sympathetic stimulation will cause vasoconstriction. You can see it because I will go back to the slide here. If you block here this beta receptor effect, then alpha receptor will cause vasoconstriction. But in normal person, in a normal living individual, there is a vasodilatation during sympathetic stimulation. This is beneficial. Why beneficial? Because whenever there is a decrease in the blood pressure to a very low level as compared to the circulatory shock, this will lead to increase noradrenergic discharge, that is sympathetic stimulation, you can say. This will lead to increased coronary blood flow. This is secondary to metabolic changes, that is decreased O2, increased CO2, increased HIN, increased adenosine, like that during shock. And this will help to preserve the function of the heart as compared to the other organs. Effect of parasympathetic is weakly vasodilator. Parasympathetic is weakly vasodilator effect. Special features about the cardiac muscle are metabolism is that they are mainly depend upon free fatty acid and to a lesser extent on glucose and lactate for metabolism. So in ischemia, anaerobic conditions will lead to deriving of energy from the anaerobic glycolysis, which will lead to increased lactic acid formation, which is a cause of chest pain. Cardiac pain or chest pain is because of anaerobic glycolysis leading to formation of lactic acid, which is causing cardiac pain or ischemic pain. This is attendance, no problem. Can you scan it? Yeah, please. Scan this code and fill the Google form and put the today's date. Okay, I will change now. So importance of coronary circulation is to know the two important conditions: ischemic heart disease, which will lead to angina pectoris. Angina means pain. Pectoris means in the pectoral region or chest. Myocardial infarction is complete blockage of the artery leading to disintegration of the muscle. This is called as infarction. Ischemia is just temporary decreased oxygen supply. What are the risk factors? Risk factors for developing ischemic heart disease are cigarette smoking, hypertension, uncontrolled blood glucose level as in case of diabetes mellitus, increased lipid or cholesterol, and other risk factors like lack of exercise and having more anxiety. All these are the risk factors. If they are there in the person, maybe likely chances that he or she will suffer from ischemic heart disease. So what is happening in ischemic heart disease? Reduced coronary blood flow due to partial blockage due to atherosclerosis or cholesterol deposition in the subendocardial epithelial plaque. Patient complains of tightness or pain in the middle of the chest, retrosternal. Here, they will typically present with a central chest pain, which will be for a few minutes. Pain often radiates to the inner side of the left arm. This will radiate to the left side of the arm as well as the left side of the neck also, followed by this nausea and vomiting sensation also. Pain will be precipitated with effort. If person try to walk or run over the stairs, then the pain will increase, whereas relieved by rest. Myocardial infarction is obstruction of the blood flow through the coronaries, almost 75% less than the normal, due to either maybe due to the blockage or by the thrombus, by plaque or thrombus. It is the most common cause of the death because of the coronary artery blockage, myocardial infarction. This is how it shows that this is the normal size and the flow, and if the artery is blocked or deposition, this will lead to decreased blood flow. Blood flow will be reduced, and the area which it supplies, it will be getting infarcted. Here it is also showing you this area is all deposition of the atherosclerotic plaque, and only partially open artery is lumen seen. This is the lumen of the artery, coronary artery, and this one is the area full occupied by the plaque. Okay, how will you diagnose coronary artery disease or ischemia or infarction? How will you diagnose? By ECG. First thing is ECG, electrocardiography. As soon as the patient feel pain or complaints of pain, he should be referred to the hospital, taken to the hospital. In the hospital, the first thing they do is they take the ECG of the patient by attaching the leads. What it will show? This is the resting ECG, and this one is the ECG in exercise, or maybe when the person is doing exercise for knowing the cardiac condition. There may be ischemic changes will be seen. How the ischemic changes will be seen? Ischemic changes will be seen in the form of ST segment depression. This is normal ST segment, horizontal line. ST. ST segment depression means it will go below the horizontal line. And another condition is called as ST segment elevation. This is increasing in the or moving up the ST segment. So during exercise, there is a ST segment is depressed here. ST segment depression is seen in the ECG. Which lead in will show the ST segment depression? Because every lead of the ECG represents a specific area of the heart, like lead 2, lead 3, lead AVF is for the inferior wall of the heart. Suppose inferior wall is having ischemia, then the ischemic changes or ST segment depression will be seen in 2, 3, and AVF. This is for ST segment elevation. This is a normal ST segment here, normal ST segment. And here minutes after the infarction starts, you will see this is the horizontal line and the ST segment is here. So it is elevated. This is elevated. This is the horizontal line and the ST segment is high up here. Okay. And after recovery, you will see again it come back to the normal position. ST segment come back to the normal after days of the infarction. But you will observe one more finding here after the infarction occur. Which wave is this? Q wave will appear. If you observe here, no Q wave or very minimal, no Q wave. If you see after the infarction, Q wave will be seen in which lead? Again, where the infarction is. where the infarction is occurring. Suppose it is anterior wall, so leads of the anterior wall will show Q wave or ST segment elevation. If it is occurring in inferior wall of the heart, then it will be seen in the inferior leads which are responsible for the inferior wall visualization. Okay. After diagnosis, what is the other investigation? Other investigations are, apart from ECG, cardiac enzymes, chemical test. You can know the CK, that is the creatine kinase, LDH, troponin. They will be elevated. Echocardiography will tell you what is the thickness of the muscle. Even in some normal cases, treadmill test, where the person is running on the treadmill with the ECG lead, can show if there is a decreased blood flow, can be seen in the ECG while exercising, that is treadmill exercise test. Thallium scan is the one where the drug thallium is given or it is a radioactive substance, and visualization of the you can say distribution of the drug. Coronary angiography is directly visualization, putting a dye inside the vein and then reaching to the coronaries, and visualization is called as coronary angiography. ECG changes in the ECG are ST depression during in the respective leads, and ECG in MI will be ST elevation. So depression in ischemia, elevation in the infarction. Treatment, you can give coronary vasodilators, beta blockers, or angioplasty surgical. That is, if you can go to the area where the artery is blocked. Let's say this area is blocked. So you can pass a tube and up to here and then dilate it. This is called as angioplasty. And you can put a stent, metallic thing is that which is kept inside the artery so that it should not block again, or can be bypass surgery. I will show you the picture. So these are the pictures of angiography, and here is the stent where you can put it where the block is occurring. This is coronary artery bypass. You can suppose the blockage is here, so no blood flow is in this area. So you can connect one end of the artery here and the another end after the blockage. This is called as bypassing the block. Again, this can be also be connected like this, internal memory artery or another vein, CAVG. Thank you very much. Now, if you have any question, you can ask me now.
Doctor,
Yes.
I have a question regarding the exam, not regarding the lecture.
Okay.
I just want to check uh, these lectures are mostly of them like the questions. I don't know how will they come. Like, would they be like the same as the slides? Is there anything other than that? Should we like study the reference book, or should we do something like that? That's the whole idea about these two